Hi, welcome to Laboratory Methods for Diagnosis of Parasitic Infections. This slide shows your objectives for this lecture. Please read over these on your own and make sure that you understand each objective before you take any quizzes or exams in this class. So what is a parasite exactly? Well, a parasite depends upon a host for nutrients, and they obtain them at the expense of the host. There are 6 divisions of parasites. We have the protozoa, nematoda, platyhelminths, pentastomids, acanthocephala, and arthropoda. Now, you may hear some of these parasite pronunciations different within your laboratory, and excuse me if I butcher some of these names. Just keep that in mind as you're going through this lecture that you may hear the pronunciations a bit different depending upon the laboratory that you work. Some of the examples are listed there of each parasite in each division. One that I don't have on the protozoa is the amoeba. Those are also considered protozoa. These are the single organisms. All right. Moving on to the next slide, these are some terms you should be familiar with. Obligate means the parasite can only live within a host. Facultative means that the parasite can live in and outside the host. An endoparasite refers to one that lives inside the body, whereas an ectoparasite refers to one that lives on the body's surface. If the host is definitive, the host is that the parasite lives its adult or sexual stage within that host. An example would be the malaria parasite, the Plasmodium species. The mosquito would be the definitive host because it hosts the sexual stage. An intermediate host, excuse me, is a host where a parasite lives its larval and asexual stage. So the human would be the intermediate host for the malaria parasite. A reservoir host are other hosts that harbor the parasite. And then another term that's on here that I would like you to know is accidental host. This is an infection with a parasite that is not normally found in the host. So if you hear that term, that's what that is. All right, so the amoeba are the first parasites we're going to talk about. These are single-celled organisms. They have pseudopods, which are used for motility. And pseudopod actually means false foot, so they extend out some of their cytoplasm and move by doing that. Entamoeba histolytica is the major cause of dysentery, and it can also cause amoebic liver abscesses. Others that we will talk about are Entamoeba dispar, Entamoeba hartmanni, Entamoeba coli, Endolimax nana, and Iotamoeba buccelli. These are non-pathogenic. They're still considered parasites, but they don't usually cause any disease or issues within the host. And these amoeba exist as a cyst stage and a trophoid stage. The cyst stage is the non-feeding stage, and the trophozoite or troph stage is the motile feeding stage. Here you can see an example of amoebic liver abscess that was probably caused by Entamoeba histolytica. All right, so here's the trophozoite stage. This form appears more amoeboid and usually about 15 to 30 micrometers in diameter, although more invasive strains tend to be larger. The organism has a single nucleus with a distinctive small central karyosome, and the karyosome is usually a darker convex clump of chromatin within the nucleus. The cytoplasm may be finely granular and may contain ingested erythrocytes. This is for Entamoeba histolytica. The nuclear chromatin is evenly distributed around the periphery of the nucleus. Size is very important when you're trying to classify amoeba and figure out which one you have. Certain amoeba look very similar, and one of the distinguishing characteristics is the size of them. So keep that in mind as you are reviewing the parasites. Here we have an example of Entamoeba histolytica trophs. And I want you to note the dark box cytoplasm here, those are actually ingested red blood cells. If you see ingested red blood cells, this is diagnostic of an entamoeba histolytica trophozoite. Here you can see the central karyosome. It's in the center, and then the chromatin that is around the periphery. It's kind of hard to point to, but I'll try here. Right there. That's the peripheral chromatin, and it's evenly distributed around that periphery of the nucleus. The cyst stage of entamoeba histolytica, they're spherical. They have a refractile wall. The cytoplasm usually contains dark staining chromatoidal bodies, 1 to 4 nuclei with a central karyosome and evenly distributed chromatin. There we have some examples of entamoeba histolytica cysts. Here's the chromatoidal body. Those chromatoidal bodies, the characteristic of them is they're more rounded and more blunt versus some of the other that you will learn about in a little bit. And then you can see again, this one looks like it has 1, 2, 3, 4 nuclei. It has that central karyosome again with the peripheral chromatin evenly distributed. Here's some more examples of entamoeba histolytica. So here is a troph with ingested red blood cells. If the trophozoite does not have the ingested red blood cells, usually as far as you can go for the diagnosis is you can say entamoeba histolytica / dispar because they look very similar. And then the rest of these 3, 4, 5, 6, and 7 are cysts. You can see that the cysts have various appearances. The top 2 are earlier cysts, and then the bottom 3 are more mature cysts. See, the cysts have 2 to 4 nuclei. Peripheral chromatin is evenly distributed at that central karyosome, and then the chromatoidal bodies being more R-shaped. Here we have some more examples of entamoeba histolytica in a stained specimen. You can see ingested red blood cells in some of these again, and then you can see the chromatoidal bodies in the cyst stage as well. Amoeba life cycle. Infection usually occurs by ingestion of the cysts on fecally contaminated food or hands. Cyst is resistant to the gastric environment and can pass into the small intestine where it decysts. And then the cyst divides into 4 and then 8 amoeba, which move into the large intestine. Majority of the organisms are passed out of the feces, but with larger bolus of infection, some amoeba attach to and invade the mucosal tissue, forming flask-shaped lesions. Those are also called bomb craters. The organisms insist for mitosis and are passed through the feces. There's no intermediate or reservoir host with the amoeba. You can see the amoeba life cycle again. I believe this picture was taken from CDC. You have the mature cysts going into excistation and forming that trophozoite. Then they're going to multiply. You'll get some trophs and cysts again within the body, and those will get passed into the feces. Symptoms, history, and epidemiology are keys to diagnosis of the amoeba. In the lab, it's usually confirmed by finding the cysts in the stool, although in more watery specimens you may see the trophozoites as well. Entamoeba histolytica infection is distinguished from dysentery caused by bacilli by the lack of high fever and the absence of white blood cells. Moving on to entamoeba coli. Here's the cyst of entamoeba coli. This cyst has 8 or 16 or even more nuclei. The chromatin is granular and uneven when it's distributed around the periphery. The karyosome is more eccentrically located, and you can splinter-shaped chromatoidal bodies in some of the cysts. I don't see any chromatoidal bodies in this one. If you look here, the peripheral chromatin is more unevenly distributed versus the entamoeba histolytica cyst. And it's kind of hard to see in this picture, but the karyosome is more eccentric. Here we have Iotamoeba bucci, troph, and cysts. The top picture are trophs. They have a large karyosome, granular cytoplasm. And then the bottom two are the cyst stage. They have a large glycogen vacuole, which you can see here. That's characteristic of Iotamoeba bucci. One nucleus and a large darkly staining karyosome. I like to think of these as looking kind of like a pop top. That's an easy way for me to remember Iotamoeba bucci cysts. All right, then we move on to Entamoeba hartmanni. Entamoeba hartmanni is similar to Entamoeba histolytica in that it looks very similar. However, Entamoeba hartmanni is only 5 to 12 micrometers, so it's a lot smaller. The troph has a solid ring of chromatin, a central or eccentric karyosome. The cyst stage, 1 to 4 nuclei, a central karyosome. Chromatoidal bodies are again blunt and cigar-shaped. The top 3 pictures here are the troph stage, the bottom 2 are the cyst stage. You can see the 10 ocular micrometers at the bottom here indicating the small size of Entamoeba hartmanni. Here we have some free-living amoeba, Blastocystis hominis. It can be pathogenic. Blastocystis hominis is still in the amoeba category, but its classification is under review. What you need to do with this parasite is report the presence and quantitate if there's rare, few, many, or packed. The diagnostic form is found in the stool, and it varies in size from 6 to 40 micrometers. Parasite is characterized by a central body that resembles a vacuole, and the central body pushes the nuclei to the periphery of the cell. Here we have Blastocystis hominis in the middle, and you can barely see the nuclei around the periphery of the cell. That large area in the middle is the central body. Some other free-living amoeba, Acanthamoeba. These have spiky pseudopods. A double-walled cyst is seen using calcifluor white, and it can cause granulomatous amoebic encephalitis. So this is a disease of the central nervous system, can be very dangerous. And then another amoeba, Balamuthia mandrillaris, causes granulomatous amoebic encephalitis as well. Looks very similar to Acanthamoeba. In the trophozoite stage, extensive branching with this one, and they have double-walled cysts as well. Naegleria fowleri has lobed pseudopods, transforms into a pear-shaped flagellate with 2 flagella. This is only a temporary stage. It will revert back to the trophozoite stage. The cyst again is double-walled and causes acute primary amoebic meningoencephalitis, another disease of the central nervous system. Okay, moving on to the flagellates. These protozoa move by their flagella, and they're acquired through the fecal-oral route. Giardia lamblia and Dientamoeba fragilis are the key ones you usually see. Dientamoeba fragilis has no cyst stage. It only has the trophozoite stage, but Giardia lamblia has both the troph and the cyst stage. Giardia lamblia is the most frequent protozoa intestinal disease in the U.S. It ranges from mild diarrhea to acute severe diarrhea to staturia and also malabsorption syndrome. The trophozoite of Giardia lamblia is 12 to 15 micrometers. It kind of is a pear-shaped with 8 flagella, 2 axostyles arranged in bilateral symmetry, and it has 2 suction discs. The cytoplasm contains 2 nuclei and 2 pale bodies. You can see the trophozoite stage here. I kind of think it looks a little bit like a kite. Giardia motility is what they call a falling leaf motility. It's kind of neat to see in a wet mount. All right, the cyst stage of Giardia lamblia is 9 to 12 micrometers. They're oval-shaped, smooth, well-defined wall. The cytoplasm contains 4 nuclei and some of the same structures that you see in the trophozoite. There's the cyst stage of Giardia lamblia, the nuclei, the axostyle, and the parabasal bodies as well. Here's a comparison of the trophozoite versus the cyst stage. The trophozoite is more pear-shaped, whereas the cyst stage is oval. And also you can kind of see the flora coming off of the trophozoite there. Infection occurs by ingestion of cysts, usually in contaminated water. The cysts then decyst, and this occurs in the duodenum, and the trophs colonize the upper small intestine, where they may swim freely or attach using their suction disc. The free trophozoites encysst as the downstream, and mitosis takes place during the encystment, and then the cysts are then passed into the stool. Here's another picture showing the life cycle of Giardia. Here you can see the troph and the cyst. Trophs are passed in the stool, like it says there, but they don't survive in the environment. The cysts contaminate water, food, or hands, fomites, and the person then ingests the cysts, and the stages and the cycle go over again. All right, here we have some flagellates that we're going to talk about. These are non-pathogenic flagellates. The first one you see is Trichomonas hominis. It has an undulating membrane as well as an axostyle. The second one is Chylomastix mesneli troph and also Chylomastix mesneli cyst. The characteristic of the cyst is this hyaline knob and also the shepherd's crook. And then on the bottom again, you see Giardia lamblia trophs and also the cyst. Dientamoeba fragilis has no known cyst stage. The trophozoite has 1 or 2 nuclei with 4 to 8 chromatin granules. It kind of gives the nuclei a starry appearance. It varies a lot in size and shape, and it may contain bacteria or debris. Here's Dientamoeba fragilis. There's the nuclei that I was talking about that kind of looks starry. And this one only has 1 nucleus. This one looks like it has 2. And again, another picture here. This one's a little bit better stained. This is the triachrome stain, and you can see the 2 nuclei here and the 1 twinkly nuclei there. Trichomonas vaginalis is acquired by sexual transmission. It's found in the genitourinary tract. It has a characteristic undulating membrane in the troph stage. In comparison to Trichomonas hominis, the undulating membrane of Trichomonas hominis goes the whole length of the organism, whereas the undulating membrane of Trichomonas vaginalis only goes half the length of the organism. Also, Trichomonas hominis is found in the stool, whereas Trichomonas vaginalis is usually found in the urine. The life cycle, Trichomonas vaginalis colonizes the vagina of women and the urethra. Sometimes it's in the prostate of men. Infection occurs primarily via sexual contact, although other infections are possible. The organism does not encysst, and it divides by binary fission, which is favored in the low pH of greater than 5.9, and then the normal pH is about 3.5 to 4.5. There's no non-human reservoir for this one. Again, this is transmitted via sexual contact. Trichomonas vaginalis, you'll see it here on the left. This is a stained specimen of Trichomonas vaginalis. You can see the flagella here. This on the right is what Trichomonas vaginalis looks like in a urine specimen. Sometimes it's very difficult to tell the difference between Trichomonas vaginalis and white blood cells because they look pretty similar in a urine specimen. So what you want to look for when you are seeing Trichomonas vaginalis is flagella and movement. If you can see the organism moving in the urine specimen and you can see the flagella, then you have Trichomonas vaginalis versus a white blood cell. Okay, that was part 1 of your PowerPoint. I'm going to try and switch it over to another PowerPoint here, and we'll start with part 2. All right, part 2, lab methods for diagnosis of parasites. Here are your objectives again, similar to your objectives from your first PowerPoint. The ciliates, there's only one ciliate that we are concerned about infecting humans. Ciliates move by their cilia, which are the tiny hairs all around the organism. The one organism that we are concerned about is Balantidium coli. You ingest this, food or water contaminated, the cysts are in that, and it's transmitted fecal-oral. It is the largest protozoan. It's about 50 to 100 micrometers. It's very easy to spot this organism under the microscope. Balantidium coli infects the intestinal tract. The trophozoites are rapid. They have rotary or boring motion, and their surface is covered by cilia. The cytoplasm contains a large bean-shaped macronucleus and a smaller round micronucleus. There you can see Balantidium coli. Here's the troph, and here's the cyst stage. You can see that large kidney-shaped macronucleus followed by the very small micronucleus, and then the cilia cover the entire organism. And the cyst stage here, again, the kidney-shaped nucleus and the smaller micronucleus. Here's a picture of Balantidium coli. Again, this is the trophozoite stage, and you can see the larger macronucleus. I don't really note the micronucleus in this one. All right, moving on to coccidia of importance. We have Isospora, Cryptosporidium, and Cyclospora. These are found in the intestinal mucosa, and they are seen more frequently in immunosuppressed patients such as AIDS patients. They are passed in the stool as oocysts, which are the infective agent, and they are usually passed via fecal-oral transmission. Cryptosporidium parvum is found in the GI tract. There have been waterborne outbreaks of this in the United States, and it causes epidemics of diarrhea. This infection occurs by ingestion of the oocysts, and these oocysts contain sporozoites. The sporozoites are then released in the GI tract. They attach and divide sporozoites. The oocyst is the mature portion, and this passes into the feces, which then infects others via the fecal-oral route again. This organism is unique in that it stains with acid fast. Here we have an unstained specimen with Cryptosporidium. Very difficult to detect Cryptosporidium, but once you do that acid fast, very easy to see that Cryptosporidium in the stool specimen. Isospora abelli is diagnosed based on finding the oocyst in the stool. These also stain with acid fast, and they follow the same course as Cryptosporidium parvum. Here's a picture of Isospora abelli in the stool, a little bit larger, so they're easier to see. Cyclospora cayetanensis. This parasite is linked to ingestion of contaminated foods, raspberries, strawberries, lettuce, peas, and these also stain with acid fast. They're a little bit larger than Cryptosporidium. Here we have Cyclospora. You can see in comparison to the other slide with Cryptosporidium stained with acid fast. These are a little bit larger. Okay, moving on to some blood protozoa. We have Leishmania. This is a flagellate. In humans, you're going to see what's called the amastigote form. It's the intracellular parasite within cells. There are different species of Leishmania. We have Leishmania tropica. This causes oriental sore or cutaneous leishmaniasis of old. Leishmania brasiliensis causes mucocutaneous leishmaniasis of the New World. And Leishmania donovani causes Kala-Azar, which is a visceral leishmaniasis. This is also referred to as dum-dum fever. Leishmania life cycle, the vector is the sans that takes the blood meal. The promastigotes are transmitted into the human, and they move from the bite site to organs within the reticuloendothelial system, such as the bone marrow, spleen, and liver. And they also move into the macrophages of the skin or mucous membrane. Here we have a picture of Leishmania donovani. These little things here are all the amastigote form of the Leishmania. And here we have an example of the Leishmania amastigotes within a cell. Here we have an example of some patients with visceral leishmaniasis. The parasite travels to the liver, spleen, and bone marrow, and this causes fever, weight loss, mucosal ulcers, and swelling within the patient. Here we have a skin ulcer that was due to a Leishmania. And some mucocutaneous leishmaniasis. Trypanosoma species are flagellates as well. You can see the three pathogenic species there. We have Trypanosoma brucei gambiense. This one causes West African sleeping sickness. Trypanosoma brucei rhodesiense causes East African sleeping sickness. I always think of gambiense. The G of gambiense, I say go west, so I can remember which one causes West African. So gambiense, go west, causes the West African sleeping sickness. And sleeping sickness causes drowsiness, fever, headaches, insomnia, some mood changes, and sweating in patients. And then the final one is Trypanosoma brucei. This causes American trypanosomiasis or Chagas disease. In patients, you'll see symptoms of fever, malaise, swelling. If chronic, it can cause digestive problems and also pain in the abdominal region. Trypanosoma brucei gambiense is very slow developing versus rhodesiense is pretty rapid progressive. Patients with this organism can have or can be dead within a year. This is transmitted by the tsetse fly. You can see here a chancre caused by the tsetse fly bite. And here we have a patient that's wasting away from sleeping sickness. Trypanosoma brucei, morphologically similar. The trypomastigote stage is it's 10 to 30 micrometers. There's a single central nucleus and a single flagellum joined to the body by an undulating membrane. Trypanosoma brucei, rhodesiense, and gambiense are morphologically indistinguishable. Here we have a picture of them. You can see the flagella, the undulating membrane, and the nucleus in the center. This tiny dot that kind of looks like an eye of the organism is called the kinetoplast. Trypanosoma brucei is more in a U-shaped, in contrast to Trypanosoma krusei. This one occurs in three forms. The trypomastigote is usually 15 to 20 micrometers. It's similar to Trypanosoma brucei. The epimastigote is found in the and the amastigote can be found in the myocardium or the brain. Here you see a picture of Trypanosoma cruzi. This one is more of a C-shaped versus the U-shape that you'll see in Trypanosoma brucei. But you can see that undulating membrane again, the flagella, the nucleus, and the cast. Okay, moving on to intestinal helminths. We have the nematodes. These are the roundworms, and then we have the platyhelminths. These are the flatworms. There are two classes. We have the trematodes, which are the flukes, and the cestodes, which are the tapeworms. Intestinal nematodes are very cylindrical worms. There are separate sexes, with the male being smaller than the female, and these are diagnosed by finding eggs in the stool. We have two organisms that actually cause disease in humans, but they're referred to as hookworms. These are Ancylostoma duodenale and Necator ammonis. The eggs are identical, so when you see them, instead of reporting the organism, you're actually just going to say hookworm egg. Nematodes are infect humans through ingestion of contaminated food or water, and they can also penetrate the skin by the infective larvae if they are in the soil. Here are some nematodes of importance. We have Enterobius vermicularis, which is pinworm. You will use the Scotch tape method to detect this parasite, and what this method does is a patient sample is taken using sticky tape from the perianal area. Trichuris trichiura is also referred to as whipworm. Ascaris lumbricoides is referred to as roundworm. Strongyloides stercoralis is passed as larva instead of as the egg, and the larvae are called the rhabditiform larvae. And then finally we have Ancylostoma duodenale and Necator americanus. These two are referred to as hookworm. Ascaris lumbricoides, you can see the egg here. The fertilized egg is broad, oval, and mammillated. You can see that mammillation. It's kind of a scalloped edge to it. And the outer covering is what is mammillated, and the egg is usually dark yellow to brown. Here we have an adult worm of Ascaris lumbricoides. They can reach up to 35 centimeters. Here's an egg of Trichuris trichiura. It's smooth-shelled, brown, kind of barrel or football shaped, and has mucus plugs at both ends. Here's another example of Trichuris trichiura. Here's the adult worm. You can see the female is a lot larger than the male worm, and the larvae are usually a pink to white color. Here we have the eggs of Enterobius vermicularis. These eggs are also kind of a football shape. They're flattened on one side with a C-shaped embryo within. Here we have the adult male and female worms. They are long, pointed, pin-like. That's why they're called pinworm. Strongyloides stercoralis. This is the rhabditiform larva. Strongyloides stercoralis is also considered the threadworm. When you are looking at rhabditiform larvae, hookworm you might also see the hookworm larva in a stool, and usually they're not passed as the larva, the hook, but if that stool has been sitting a while, the eggs can actually hatch and release the larva out. So it's important to be able to differentiate the rhabditiform larva of Strongyloides from larva of hookworm. What they look for is the buccal cavity of the worm, and also the genital primordium, which is somewhere around this area. I don't really see it very good in this picture. Strongyloides stercoralis has a short buccal cavity and a prominent genital primordium. I think of it as the short and sexy worm versus hookworm, which has a longer buccal cavity and a smaller genital primordium. Here we have hookworm eggs. They're oval, colorless. They have a very thin shell. Again, we can't differentiate between Necator americanus and Ancylostoma duodenale. We just say hookworm egg. Here we've got a close-up picture of the hookworm adult worm. We tell the difference between Necator americanus and Ancylostoma duodenale by looking at the anterior end. This is Necator americanus, which has cutting plates. You can kind of see that there. Versus Ancylostoma duodenale has buccal capsules with teeth. Here we have a tissue nematode, Trichinella spiralis. This is caused when you get ingestion of raw pork or bear. It's found in the muscle. This is the larva here. Kind of forms that spiral shape. And we have Wucheria bancrofti. You get this from the bite of a mosquito. It infects the lymph and blood. It causes elephantiasis, and it is diagnosed by a blood smear. Wucheria bancrofti has a sheath. It's a little bit more difficult to see in the stained blood smear here, but it's on the outer edge of the organism. And the sheath has nuclei that extend to the tip of the tail. That's how you can tell the difference between this and other filarial forms. Here's a picture of elephantiasis caused by the filarial parasite. Other nematodes, we have Onchocerca volvulus. You get this from the bite of a black fly. And this infects the skin, eyes, and nodules. It can cause what's called river blindness, and it's diagnosed by a blood smear. Actually, let's go back to this one here. This should be diagnosed by a blood smear, should be under some of the other filariform larvae, not Onchocerca volvulus, because this picture shows diagnosis from skin snips. You can actually see it in some skin snips. This organism is unsheathed. Nuclei do not extend to the tip of the tail. Loa loa is caused by the bite of a black gnat. It infects the eye. Diagnostic specimen is blood, and this infection is called African eyeworm. If we look here at this picture, you can see that it's sheathed again, a little bit harder to see, but the nuclei are continuous to the tip of the tail here. And this is another view of Loa loa. Other nematodes, we have Brugia malayi. This is caused by the bite of a mosquito. It's found in the lymphatics and blood, and it's diagnosed again by the blood smear. This one again is sheathed, and there's a pair of nuclei that extend to the tip of the tail. You'll see two. It's kind of difficult to see in this picture, but you'll see two nuclei at the tip of the tail. Okay, moving on to intestinal cestodes. These are the tapeworms. They're long, segmented, and ribbon-like. They have a scolex at the end, which is the attachment to the small intestine. The adult worms live in the small intestine. You get them when you ingest contaminated food, and they are transmitted fecal-orally. Here we have an adult tapeworm. They're quite long. They just keep extending and extending their segments. The segments are also called proglottids. Here are some intestinal cestodes. We have Taenia saginata, which is the beef tapeworm. Taenia solium is the pork tapeworm. Both of the eggs look alike, so you need the proglottid or the scolex to identify them down to the species level. Other cestodes of importance, Diphyllobothrium latum. This is the freshwater fish tapeworm. Hymenoletta, tapeworm eggs, you can see. The diminuta, you get this from grain beetles, and Dipylidium caninum, you can get this from the fleas of dogs or cats. All right, Taenia saginata is the beef tapeworm. The scolex is pear-shaped. It has 4 suckers. There are no hooks in it. It's long, has a flat body with several hundred segments. The segments, again, are also referred to as proglottids and can get very, very long. Taenia solium is the pork tapeworm. It's slightly smaller than saginata. The scolex is globular and has 4 suckers. It has hooks and it also has a neck. This parasite can also get pretty long, proglottids measuring 5 to 10 millimeters. Here we have the Taenia eggs. Characteristic of these eggs are the radial striations that you see in the shell. Again, you cannot say whether it's Taenia saginata or Taenia solium unless you're looking at the proglottids or the scolex of the worm. You can just say Taenia species. Here we have a proglottid, and this is how you would differentiate between Taenia saginata and Taenia solium. The differentiation is based on the number of uterine branches in the gravid proglottid. So Taenia saginata, you can see, has more uterine branches per proglottid, usually 15 to 25 if you would count. And over here, Taenia solium has 7 to 14 uterine branches. Here we have a picture of the scolex of Taenia solium. It has hooklets and suckers. And then the gravid proglottid has 7 to 14 uterine branches. All right, Diphyllobothrium latum. The eggs of Diphyllobothrium latum will be shown on the next page. We're going to look at the proglottid first. The tapeworm is ingested, or the eggs are ingested through raw freshwater fish. It's the longest tapeworm that's found in humans, and the proglottids are more broad. When you look at the Taenia saginatum and solium, they were a little bit longer. These ones are kind of more rectangular shaped. All right, here's the egg. The eggs are oval shaped. They have an operculum at one end, which is kind of a lid on the egg, and then a small knob at the end. Here's just another picture of that, the operculum at this end and that small knob there. Dipylidium caninum. This egg comes as a packet. They're colorless eggs, and they each have a 6-hooked oncosphere inside of them. So each one of these is an egg. The scolex of Dipylidium caninum has 4 suckers. Okay, here you can see the proglottids of Taenia saginata, Taenia solium, Diphyllobothrium latum, and Dipylidium caninum. So if the proglottids are passed into the stool, you can use these pictures and the criteria that we've learned to diagnose based on the proglottid that you see. Hymenoletta nana is called the dwarf tapeworm. It infects children mostly. Rodents are the reservoir of it. You get it fecal orally. There is no intermediate host. The eggs of this parasite have what's called polar filaments. See it here, it's kind of a grayish egg with polar filaments here. You can see some hooks within the egg. Hymenalepis nana, another picture again. You can kind of see some of the polar filaments within the egg. Then we have Hymenalepis diminuta. The egg looks very similar to Nana, except it's larger. It has a striated outer membrane, and there's no polar filaments when you look in this area. You can see some hooks in there, just like Nana, but does not have the polar filament. All right, tissue cestodes, two that we're going to talk about, Echinococcus granulosus and Echinococcus multilocularis. You get this through the ingestion of eggs. They're found in the liver and lung. Granulosus eggs come from the dog tapeworm, and multilocularis comes from the fox tapeworm. Tesolium can also be found in the central nervous system. Here we have Echinococcus granulosus. It's the smallest of all tapeworms. It only has 3 proglottids total, one here, and one here. The eggs are rarely recovered in humans, but if you do see them, they are Volcania eggs. Intestinal trematodes, we're going to move on to the flukes. Flukes are ingested. The Metasticariae are the house parasite. They're found in the intestine then. Some important flukes that we're going to talk about are Phaseolopsis buski. You can get those from eating water chestnuts. Heterophes, and Metagonomus yokogawa. Those are you get from raw fish. These ones are seen more in Near and Far East Asia and Africa. You can also see Metagonomus yokogawa more in Asia and Siberia. There's the egg of Phaseolopsis buski. It's oval, very large egg, about 130 micrometers, and it also has an operculum or a lid on it. Heterophes, and Metagonomus yokogawa. The eggs are indistinguishable from one another. They're smaller eggs, operculated, and they have a shoulder. You can kind of see the operculum here. The shoulder isn't very visible, but it's usually right around there. Heterophes, again, this is more common in the Near and Far East and Africa. And Metagonomus yokogawa, you'll see that in Asia and Siberia. The liver trematodes are found in the liver, and you get these through the ingestion of the Metasticariae. You diagnose them by seeing the eggs in the stool. Two that we're going to talk about are Fasciola hepatica. Get these from watercress. The eggs from Buski and hepatica look very similar. Clonarchus sinensis, that egg looks a little bit different. It's smaller. And you get this one from raw fish, and this one is called the Chinese liver fluke. Here we have Clonarchus sinensis. The egg is similar to Heterophes, but it has a more prominent shoulder. And there's the operculum. That's smaller. Sometimes textbooks refer to this one as looking like a flask with a lid. All right, Paragonomus species. You sometimes will hear it called Paragonomus westermanni. Get this through the ingestion of the Metasticariae in raw crabs. It's found in the lung, and you can diagnose it by seeing the eggs either in the stool or the sputum. Here we have an example of Paragonomus westermanni egg. Has a thin shell, but it thickens at the operculum. All right, moving on to blood trematodes. Snails are the intermediate host of these trematodes. In the human, they're found in the veins over the large intestine, the bladder, and the small intestine. And you can see them either in the urine or the stool. Three that we're going to talk about are Schistosoma mancini, Hematobium, and Japonicum. Schistosoma hematobium is the one that you can see in urine. The other two, you will more than likely see those in the stool. Schistosoma mancini is seen in Africa and America. Characteristic of this egg is that it has a lateral spine, and you will diagnose this by seeing the egg in the stool specimen. Schistosoma hematobium, you'll see this in Africa. This one has a terminal spine, and you will see that in the urine. Schistosoma japonicum is seen in the Far East. It has a very, very small lateral spine, kind of hard to see in that picture, but here's a closer up picture of it. That's how we tell the difference between the schistosomas, is looking at where the spine is located and how large it is. All right, that is it for parasites. Be sure when you are studying for your exam that you go over the pictures. You have an idea of how to describe the pictures. If something was asked of you like, could you tell me the difference between what the Giardia lamblia and the cysts look like? Be able to understand how to describe where the parasites come from, how you get the organism, if there's a vector involved, that you can identify which vector it is. Was it the tsetse fly? Is it a sand fly? Is it a black fly? Those kinds of things. And be able to tell me which of the amoeba are pathogenic versus which ones are commensals, meaning that they're just living in the organism but not causing any damage. All right, that's it for a parasite lecture. We'll see you next time.